A little over 1 week, we're out from Thanksgiving. It's a holiday that brings family, friends, colleagues together around food. Appropriately, BPC is issuing its report today entitled A Healthy Eating Prescription, Improving Nutrition Through Healthcare. Good morning, I'm Bill Hoagland, Senior Vice President here at the Bipartisan Policy Center, and I have the pleasure of working with our health project, focusing on improving health for all, for reducing cost, and bettering the quality of care provided. Unfortunately, I think we all know that most Americans have poor diets that can lead to preventable illnesses, including type 2 diabetes, cardiovascular diseases, and even some forms of cancer. It is estimated that nearly $400 billion of our healthcare dollars are spent annually on diet-related diseases. So what can we do to reduce those costs while improving overall health? The report issued today provides bipartisan recommendations related to two key topic areas. The first is training healthcare professionals and educating patients and public on nutrition. And the second area is engaging healthcare professionals in interventions intended to lead to the consumption of more healthy foods. We will discuss those interventions, including referrals for dietary counseling or food as medicine interventions, namely medically tailored meals, medically tailored groceries, or produce prescriptions. But first, thank you to our four co-chairs, former Secretaries of Agriculture Ann Veneman and Dan Glickman, and health leaders, former Majority Leader Senator Dr. Bill Frist, and former HHS Secretary Donna Shalala. They will provide some framing comments shortly. And of course, thank you to the BPC staff led by Shannon Christop, our Public Health Director, including Kathy Adams, Emma Sheffert, Eden Kennedy, and our Chief Medical Advisor, Dr. Anand Parekh, along with our consultant on this project, Melissa Martin Shepard. We also developed these recommendations by receiving input from experts that participated in our roundtables and an expert group in our food and medicine working group. It was comprised of healthcare providers, health professionals, food producers, academics, and nutritionists. Shannon will give a shout out to each of those highly respected professionals in her opening comments. And none of this would be possible without the support of funders: Walmart Foundation, Amazon, Evelyn Health, Instacart, Kaiser Permanente, and Grocer. A spoiler, first of all, stay tuned because we have a Thanksgiving treat for you brought to us from Food and Friends. And at this time, I want to turn this over to our first co-chair and former Secretary of Agriculture, Ann Veneman.
Good morning, and thank you for joining the Bipartisan Policy Center. It has been an honor to co-chair the Food is Medicine Working Group with Secretaries Dan Glickman and Donna Shalala and Senator Bill Frist. As diet-related diseases continue to increase, it becomes more important to make healthy foods accessible to those dealing with diabetes, cardiovascular diseases, and obesity. It is estimated that poor diet accounts for around $50 billion in healthcare costs per year. One focus of this report is the critical importance of increasing nutrition education for healthcare providers. A 2018 survey found that only 14% of resident physicians felt they were adequately trained in nutrition education. Other healthcare providers, such as physician assistants and nurse practitioners, report similar levels of inadequacy in their nutrition education. Also, primary care providers are often confused about when to refer patients to other experts, such as dietitians. Patients overwhelmingly trust their primary care providers to provide up-to-the-date and actionable healthcare advice. If primary care providers are not properly trained to educate patients on healthy eating, people may turn to less reputable sources for nutrition information. Proper physician advice and guidance can empower patients to change their eating habits and improve their health. This report recommends 10 bipartisan policies for increasing access to food as medicine services. It is critical that lawmakers come together and address diet-related diseases and lack of nutrition education. Thank you again to all the experts who helped create this report and who continue to work on increasing access to and education about healthy foods.
Good morning, everyone. I'm Dan Glickman, one of the co-chairs of the Bipartisan Policy Center's Food is Medicine Working Group, working along with my esteemed colleagues, Secretary Ann Veneman, Secretary Donna Shalala, and Senator Bill Frist. So we're delighted to be here for the release of our Food is Medicine report. We at the BPC have been working on these issues for a very long time. This is, I think, an extremely important report in trying to deal with long-term health care costs associated with the preventable items with American diet. So poor diet quality is not just a matter of personal choice. It's really a systemic problem affecting nearly all Americans in this country, from the lowest income Americans to upper income Americans. It's the root and leading cause of preventable disease and deaths in our nation. And it is something that involves cardiovascular disease, cancer, COVID-19, type 2 diabetes, and various other health conditions which are largely preventable. So I'm going to read from some of these statistics because I think they're really important to hear. The statistics are alarming. For example, a staggering 37 million U.S. adults, roughly 1 in 10, suffer from diabetes, with another 96 million, almost 100 million people, 1 in 3, grappling with prediabetes. I happen to be one of those, many of whom are unaware of their condition. Fortunately, I do my best to deal with it. The ripple effects of poor diet quality extend far beyond individual health as well. An analysis from Harvard University and Tufts University estimates that poor diets result in a whopping $50 billion in cardiometabolic disease-related costs each year, largely diabetes, but the other diseases I mentioned as well. Moreover, a 2021 Government Accountability Office report revealed that government spending, including Medicare and Medicaid, account for more than 1/2 of the $383 billion total healthcare spending in the United States. These are not just numbers. They represent a significant financial burden on our healthcare system and taxpayers and our efforts to reduce the federal deficit. As a former Secretary of Agriculture, I understand the importance of increasing the availability and affordability of healthy foods. I worked with the BPC previously to release a report on the 2022 Farm Bill and increasing access to important services such as the WIC program and SNAP as well. The accessibility and cultural appropriateness of foods also play an important role in shaping diet choices. A key issue is nutrition security and access to healthier foods. As the burden of diet-related diseases fall on healthcare systems that care for patients, these same systems should step up and aid in providing healthier foods to patients. This report addresses interventions such as medically tailored meals that can provide these services, and also provides efforts to ensure that our medical profession is being properly trained in helping patients cope with these preventable diseases. There's an old French expression, you are what you eat, and that is certainly true with our healthcare profession. And this effort, this report, I think can be a transformational effort to improve the quality and the importance of the American healthcare system, reducing costs and extending lives of all Americans. Thank you very much.
Right where it is. Good morning. Thank you for joining me and my very distinguished colleagues, Secretary Dan Glickman, Secretary Ann Veneman, and Senator Bill Frist at this Food is Medicine release event. It's been an honor to co-chair this working group and to hear from many experts over the last few months on this very important topic. I personally have learned a lot. The Food is Medicine approach underscores the crucial role that nutrition plays in healthcare. It emphasizes the interventions where nutrition and healthcare intersect It primarily focuses on providing nutritious foods to help treat diet-related illnesses. This approach recognizes the impact that healthy food has on our health outcomes. One of the foremost challenges, though, is the payment system, the lack of consistent insurance coverage, and both in the private and public sectors. We're encouraged with the increasing number of Medicaid Section 1115 waivers to cover nutrition and FIM services. Addressing this issue in the future will be extremely important. We know that individuals with diet-related conditions, we could actually prevent approximately 1.6 million hospitalizations every year. And we could save billions of dollars over the years. Private health plans have started to get into the business of covering produce prescriptions, for example. So thank you again. I look forward to the release. I'm sorry I can't be with you today. Have a good day.
Good morning, and thank you for joining the Bipartisan Policy Center at this important event. You know, it's been a real honor to co-chair the Food is Medicine Working Group with my esteemed colleagues, Secretary Dan Glickman, Secretary Ann Veneman, and Secretary Donna Shalala. As a physician, when I look back on my own medical education, we barely scratched the surface when it came to nutrition's impact on health. Yet today, we are facing an epidemic of diet and lifestyle-driven chronic diseases, which cost Americans over $1 trillion every year. We need to address the inadequate levels of nutrition education in medical and healthcare training to ensure that healthcare professionals can effectively guide patients towards healthier dietary choices. Food has the power to heal. And we're finally recognizing this with more than half of all Medicare Advantage plans offering some type of meal benefit. This report aims to provide actionable ways that the Biden administration can continue the work started by the White House Conference on Hunger, Nutrition, and Health by addressing the current gaps in education, promoting collaboration, and advocating for policy changes. We also call on medical schools and accreditation bodies to increase the required nutrition education at all levels for all providers. Yes, it's time we equip our caregivers with the knowledge and skills to use food as medicine.
This year. As Bill alluded to, I'd also like to thank our working group members who assisted us throughout this process, including Beatrice Abiero from Instacart, Dr. Shantanu Agrawal from Elevance Health, Aiken Demian from American Hospital Association, Matt Isles from American Health Insurance Plans, Holly Friestadt from the Milken Institute, Dr. Preetish Gandhi from Walmart Health, Dr. John Lumpkin from Blue Cross Blue Shield North Carolina, Dr. Suja Matthew from the American College of Physicians, Dr. Dari Musafarian from Tufts University, Karen Murphy from Geisinger, Taylor Newman from Kroger, Pam Schwartz from Kaiser Permanente, Dr. Kevin Volpe from American Heart Association, and Lori Wright from the American Academy of Nutrition and Dietetics. Next up, a cooking demonstration by Food and Friends. Food and Friends is a CBO here in DC that provides home-delivered, medically tailored meals and medical nutrition therapy to individuals with cancer, HIV/AIDS, and other serious illness.
Hi, this is Becca Kahn, Nutrition Services Director at Food and Friends, and I'm excited to share this medically tailored meal with you all at the Healthy Eating RX Conference by the Bipartisan Policy Center. In just a moment, I'm going to be joined by our chefs, and we're going to prepare this sunshine bowl for you.
Welcome to Food and Friends. My name's Chef Rashid Abdulrahman. I'm the executive chef here at Food and Friends. And today I'm joined by my co-executive chef, Trevor Mullins, and Rebecca Kahn. She is the head of dietitians. Rebecca, can you tell us what you do as a dietitian here at Food and Friends?
Sure. So my team does both the nutrition counseling and education with all of our clients here on service. And we also work really closely with your team to come up with the medically tailored meals that we send to all of our clients.
And Trevor, what do you do at Food and Friends? Or I should say, what don't you do?
Well, I assist you, of course.
Okay, well, I appreciate that. Thank you so much. Today we're going to be preparing a sunshine bowl. We call it a sunshine bowl because every time you eat it, it makes you smile. So the components of the bowl are, we have freshly prepared quinoa, there's brown rice, we have roasted sweet potatoes, there is, garbanzo beans, and because we're preparing food for people who are living with serious illnesses, so we also really want to focus on low salt intake. So we're using a salt-free spice, which is a blend of dried herbs, as well as a selection of fresh herbs. And then we're going to finish the dish off with a dressing that Rebecca's going to make for us today. So Chef Trevor starting us out. The first thing that we want to do is start to dice our sweet potatoes. This is pretty simple. Again, we're not using any salt. He's going to dice the potatoes. We're going to use a little bit of oil to coat them with, and then hit it with some of this 7 spice. So, okay, Trevor, any thoughts on sweet potatoes?
Well, sweet potatoes, of course, is it's really great because it's high in fiber.
Mm-hmm.
It's also it's a great starch.
Yeah, and one of the reasons we're using the sweet potatoes is because it adds a nice sweetness and a different bite. We do have, the quinoa and the brown rice are soft, and there are different flavors, different components, different textures, but the sweet potato just adds another dimension of flavor. One thing I want to point out though, during my research, I found that there's 120 different varieties of quinoa. And one of the things about quinoa is it's a complete protein in the sense that it has a lot of nutrients, it has fiber in it. So Trevor's going to go put these in the oven. All right, so now we're pretty much ready to move to the next stage. We have already cooked off the quinoa. We've already cooked off the brown rice. Our sweet potatoes are roasted, just to save a little time here. We got some garbanzo beans that are cooked off. Since we have all our components together, the next step is to make the dressing. Rebecca's kind enough to make the dressing for us today. So this is a pretty simple vinaigrette. It's like a 3-to-1 ratio. So we're going to have some of the components are Dijon mustard. We also have lemon juice, a little honey for sweetness to balance out the acidity of the lemon juice. And again, because we're not using salt, we want to add more flavor, more spice. We're using the 7 spice, which is really popular. We use it a lot, but you can get different components of the flavors, different herbs that are mixed in there. Sure.
Definitely want to make sure that there is not added salt in the recipes we're preparing for our clients. A lot of people come to us with heart disease or diabetes or a lung disease, and they really can't deal with a lot of salt or sodium. So we're making the meals really designed for their health conditions.
Yeah. All right, so far we have our lemon juice in the bowl. There's some Dijon mustard, and we're putting the honey in there, okay?
Yeah.
So I see the makings of a great salad dressing here. All right.
And the seasoning is really to taste, but we have a recipe here we follow. But if you're doing this at home, I'd say
that's right. If you like it a little bit more, more herbs in there, there's nothing wrong with that,
it. Yeah.
Okay. So while she's stirring that, I'm going to go ahead and incorporate the oil. So it's important. The Dijon mustard is an emulsifier, and it helps keep the dressing together so it doesn't break, because oil and water, oil and liquids typically don't want to play together. They're not friends, but we're going to make them be the bestest of friends ever. So here we go. So we're going to drizzle this in. She's going to whisk, whisk, whisk. Yeah, look at that. She knows what she's doing. All right.
I learned from the best.
Wow, that's really good.
That is good.
It's lemon forward.
Yeah.
And the honey hits your mouth.
There's just enough honey. It's not quite sweet.
It's not too sweet. That's right. Okay.
Good.
Okay, so now we're ready to start mixing our components together. While we're doing that, Chef Trevor is going to be chopping the herbs for us. Thank you for the bowl, Rebecca.
You're
All
welcome.
right, so let's see. Does it matter what we put in the bowl first? I don't think so. We're going to just start off with about 1.5 cups of this delicious quinoa. You can see it's nice and fluffy. It's all fully cooked. It smells wonderful. We're going to next add some of this brown rice. Again, this is about 1.5 cups. The thing about it is for the grains, I'm using equal portions. And then I'm going to mix in about 1 cup of the sweet potatoes that we've cooked. All right.
And those are roasted.
These
sweet
are the
potatoes.
roasted sweet potatoes. That's right.
Yeah.
You could steam them if you wanted, but the thing about making a bowl like this, you want to try to get coax as much flavor out of every component as possible. And I find that roasting does like a really good job. Yeah. All right. So now we have our chickpeas. Again, about 1 cup of that. Garbanzo beans. Let's see. And what else do we need? We need the kale, the greens. Yeah. So you could use kale. These are collard greens. And I think we normally do use kale for this dish, but that's okay. Today it's going to be collard greens,
Yeah.
The nice thing about this bowl, you can tailor it to however you want it. Okay, Trevor, can you add some of those greens? All right. I think we need some more basil in there. What do you think? You want to chop some? Yeah, let's chop some basil. You got the cilantro, the oregano, and some basil. Again, if you like a different type of herb, if you have a specific taste profile you're looking for, you could use any old herb. It doesn't matter. It's just whatever you like.
I just wanted to point out that you're explaining how versatile this bowl is. And
Yes.
it really is a very balanced, nutritionally, strong
We'll put the rest
bowl. And this is where we see the difference between a medically tailored meal and something that we're just going to call a versatile, healthy bowl for somebody who's not dealing with some serious illnesses.
Right.
So there are a lot of people on our service who, can use some of the differences here. But what makes a medically tailored meal is taking your expertise of knowing that the sweet potatoes need to be roasted and the dietitian's expertise of knowing that, the sweet potatoes are ultimately too much for people who are on dialysis.
Yeah.
So there's a difference between, something that can be advertised as a generally healthy meal and a medically tailored meal.
Yes. And the wonderful thing about Food and Friends is that the dietitians and the chefs work together, and we come up with the meals. The chefs help think about what meals components to put together, what we can offer, what clients might like based on some of their previous taste buds. But then we also refer to the dietitians who direct us like, it needs more carbs, it needs more starch, it needs more healthy things, and it's a nice marriage because it really works together well, because we also benefit. We learn a lot from working with the dietitians, and yeah. Okay, so I think the next thing we're going to put in this bowl is some of the spice, the 7 spice. Again, this is a salt-free spice. If you want to add that to it, yep.
The rest of this?
No, just about half.
All right.
That's good. Okay, that looks great. All right, now what we're going to do, we're going to mix in some of this delicious dressing. Okay, so we're just going to drizzle this in. I can't even say that word. Okay, drizzle it in. All right. And we may need all of it, we may not. Let's just mix it together. You got some of those spoons over there? Yeah. That's okay.
They already.
Okay. All right, so now that we have all the components mixed together, now comes the fun part. We all get to taste it. All right, so you guys got your spoons?
Got it.
All right, go ahead, dig in. Let's do this. I want to try to get some of the chickpeas, some of the sweet potatoes. Hold up. Wow.
Really good.
It's fresh too, That's the great thing about it. I'm tasting like
right.
Yeah, very bright. I'm tasting the lemon. I was going to say that. And then the herbs. It's the sunshine. That's right. That's right. It's really good. Okay, Rebecca, can you hand me that bowl, please?
Yep.
I'm going to go ahead and plate up a version of this. Yep, thank you very much. And so I guess the other thing, too, do we have to be concerned about portion control for our clients? Can you talk about that?
Yeah, that's why we use this specific scoop here in every portion of the meals that we're sending. Again, it's a medically tailored meal. So we want to make sure that if there isn't enough of the greens in the main dish, that we have the side of the extra greens here, like you're portioning. That's how we would send it to our clients, so that they have a lot of fiber to balance out the the other starch in the meal.
Yeah. Okay. Hey, you know, we happen to have some of the prepared trays that we send to our clients. So this is a version of the Sunshine Bowl, and you can see by the label, like anything that's checked off. These are the different diet types that we service. Thank you, Trevor. And everything is checked off. That means that client can have it. Can I see the alternative version also?
Yeah.
So, because go ahead.
No, I was just
So
going
who
to
gets this one?
say that this one is something that we came up with as an alternative, really for the people who are on service for end-stage renal disease, or oftentimes people who need a lower fiber diet. So it doesn't have the sweet potatoes, it doesn't have the quinoa, it doesn't have the brown rice, and it's a nice kind of warming ginger carrot that you guys came up with here. So again, a lot of people who are on service for a specific kind of cancer treatment, who need something a little milder, low in fiber, and folks who need lower potassium, lower phosphorus, people on end stage renal disease, on dialysis, they'll get this meal, which is also delicious.
Yes. And I think the thing that's really great about medically tailored meals is that I know there are some other providers out there that say they're medically tailored meals, but really, you know, it's important to have dietitians like Rebecca and her staff in-house, because one of the things that they do is that they have communication with the clients, and they help guide the clients and talk to them about, you know, further further needs. And one thing here at Food and Friends, our goal is to help people get better, and we educate them during that process so that as they go off service, that they will become healthier and make really great decisions for themselves, right?
That's exactly right. Yeah,
Yes.
our goal is to have people in a better place with their health than when they came on our service, and our education and medical nutrition therapy sets them up for success when they aren't getting our meals anymore.
And that's why we don't send hot dogs and French toast, right?
That's right.
All right. Well, thank you all so much. We really appreciate you taking the time to view our video. And, you know, hey, stay healthy.
Well, thanks for that wonderful video from Food and Friends, and you can find that recipe on our website. Now I'm going to be joined by two doctors, a PhD and MD, to discuss nutrition, health, healthcare training, food as medicine interventions, and a whole host of other things. Many thanks to Kofi Essel, Food as Medicine Director at Elevance Health. He's a pediatrician who previously worked as the Director of Culinary Medicine program at George Washington University School of Medicine and Health Sciences. And I'm also pleased to be joined by Lori Wright, PhD, President of Academy of Nutrition and Dietetics. And like many in the field, she has some background on the unique needs of individuals with HIV/AIDS as well as the elderly. So many thanks to both of you. So both of you have sought out additional educational opportunities related to nutrition and sort of helped implement various programs. How important is it for all clinicians, including physicians and others, to receive additional education about how to talk to their patients about improving their diet?
Kofi, would you like to start us off?
I can kick it off. Happy to do it. So I think it's critically important that providers of different backgrounds are trained on this topic of food and nutrition. One of the reasons I think is really important is that, you know, we learn about all these other tools in our training, right? Suturing and motivational interviewing, medication management. But one of the most powerful tools that we can use to improve the health of our patients, food and nutrition, we don't learn too much about that. And we've talked about that a little bit over this last hour. So it's a critically important tool that we don't learn enough about. The second thing I would say is that it's an important tool to build confidence. A lot of the reasons why a lot of providers don't feel that they can talk about this topic with their patients and families is because they lack the confidence. They didn't have the training. They lack the confidence to be able to talk about it and to have that self-awareness of how this food and nutrition impacts their own health as well. And the last thing I would say is that we want to protect our patients and families. We want to, what we would call, do no harm. So how do we do no harm? A lot of what we do, and when we talk about food and nutrition now, without the training, without the background, is that we say this stuff in a way that's very stigmatizing, that's very off-putting to our patients and families. It doesn't recognize the cultural nuance to the experiences that all of our families have, and that nutrition is not a black and white experience. And we don't really recognize all of these different backgrounds and experiences of our patients and families. And as a result of that, we do more harm than we do good when we talk about this. I should mention this at the beginning. The goal of non-dietitians should not be to become RDs, right? MDs should not become RDs. We can't do that. What the RDs do is critically important. They're well-trained, and we could never do what they're able to do. but we want to make sure we're complementing, we're aligning alongside these other experts and moving this message forward and supporting our families in a variety of different ways. So those are some of the reasons we should do that.
And Lori, what would you add to that?
I concur 100%. And the Academy always supports that all health professionals, including physicians, get that basic nutrition. It is a science and it is so powerful. So how can we support clinicians in providing evidence-based materials and guidance, but then also knowing when to refer on? That we are always going to be stronger as a team in supporting our patients, improving their dietary intake and health through good nutrition.
Thank you for that. What are some lessons learned from your work in training clinicians about nutrition? Lori, you want to start this one off?
Well, most of my practice has been in training future dietitians. I was fortunate enough to practice in the VA healthcare system, which is very interprofessional. So not only was I training my own dietetic interns, but also physicians, med students, physical therapy, social work. And it really is, I think, what's most important is the value of nutrition in health, not only in prevention, but in our settings too, in complementing the overall treatment of various disease processes. But further beyond that value is then working together, making those referrals and really bringing the team together in a more holistic way, treating the whole person. And so we need to look at not only, what's the best diet for right now? We need to look at then when they're going home, what are their support systems? Do they have access to food? Do they have cultural differences that we need to incorporate, personalize so that they can be most successful? So I think those are really important points in what I've learned in training, is that we need to provide that training that allows us to look at the whole person and support them, not only with nutrition, but in and beyond.
Great. Kofi, anything you would add to that?
Yeah, I can add to that. Those are really great points. I think, I've had the opportunity to train a lot of different kind of health providers as well over the years, which has been an honor and a privilege to be able to do, especially students. And most recently, one of the roles I had was director of culinary medicine at George Washington University School of Medicine and Health Sciences, working under the infamous Dr. Tim Harlan, who came out of Tulane to George Washington. So I had a chance of directing this program, working with students, working with faculty, working with community members, and it was a great, great honor. Some of the things that I learned in this role or in this opportunity that I had leading this class was the importance of teaching about food and nutrition or culinary medicine through a food and nutrition security lens. So let me take a step back. For those who don't know what culinary medicine is sort of mixing together the art of food and cooking with the science of nutrition and medicine. So what does that mean? We're getting in the kitchen, in the lab, what we call the kitchen, and we're cooking together. We're learning the power of food for our own health. And then what else? We're learning how to then communicate it towards other patients as well in a very practical way, where we're using food as the centerpiece, not just nutrients, which are important, micronutrients, vitamins, minerals, key, but we're talking through a lens of food, very pragmatic, very practical for the student, and then also in how they communicate it with their patients and families. So the first thing I would say is teaching through a lens of food and nutrition insecurity is key. Why do I say that? Well, a lot of healthcare providers in particular oftentimes come from middle to upper income backgrounds, right? So oftentimes there's already a socioeconomic discordance with themselves, their backgrounds, and their patients as well. If we just teach the lived experiences of our students, oftentimes there's a disconnect or a misalignment with how they then are able to communicate it to their patients and families. So understanding health-related social needs, understanding social determinants is key. And food and nutrition security are key components of the training in which we can talk about this topic, this very important topic. The second thing I would say that is really important is the importance of investing meaningful time and experiential learning. There are many different kinds of learning opportunities here, and a lot of the listeners who are on this call right now, I know are really putting forward some great didactic tools that are out there. Teaching tools are very powerful. Experiential learning takes those didactic tools to another level, really gets your hands dirty and gets involved in the learning process. And it's a very active form of learning. We need meaningful time to make this really stick. Why is that? Well, by doing a 2-hour session or workshop with your students, that's not really going to meet the need of our students, right? 1985 groundbreaking report from National Academy said at baseline, we need at least 25 hours of nutrition education across the board. Most medical schools aren't even reaching that minimum number. The majority aren't even reaching half, or a third aren't even reaching half of those hours. So we know that there's a lot there that's missing. If we don't have meaningful time, we're going to miss out on great training opportunities. When I was in the kitchen with my students, one of the things that I was really caught up by was their profound confidence in being wrong, in their confidence in assuming that what they knew was so right. And why was that? Well, we all, to some degree, have this expertise around food and nutrition that we think we have. Why? Because we all have our own lived experiences growing up, working, eating food each and every day. Because of that emotional tie that we have from our childhood and even to this day, we oftentimes think we understand things to a degree that we really don't oftentimes. So having that time allows these ideas, these concepts to bubble to the top, have these real meaningful conversations, and then at the same time, shatter those preconceived notions, those stigma, that bias, and then at the same time, reinvest and infuse new knowledge, new approaches to incorporate into our own learning, and then of course, how we talk to our patients' families. The last thing I'll say about this, the lesson that I think was really important is that our students are thirsty for this. Our trainees, our residents, our fellows, our medical students, our non-medical trainees, physical therapists, occupational therapists, they're incredibly thirsty for this information. When they get in that kitchen space and we start having these conversations, they start preparing these meals, they're asking questions for their own self. Well, I always thought X, Y, and Z. How do I make this food better? What do I do to improve my health in this and that way? How do I talk about this with my patients and families? So there's an incredible thirst to talk about this for their own health, and then of course, how to then communicate it to others. So those are a few lessons that I learned in teaching my students and faculty.
Great, wonderful. Appreciate those comments. Shifting gears a little bit, we've talked about the providers. We're going to talk a little bit more about the patients. What are the benefits to patients of having a conversation with their clinician about an improved diet? Kofi, you want to start this one?
Great question. Benefit to our patients. So, I think that we need to understand, and I think we do understand, and no matter what's being said now, that patients have a lot of confidence and trust in their providers, right? There's an innate trust in their providers that we get a chance to really further build, or we can shatter as well. So with that innate trust that's there, we have to recognize how can we build off of that trust and that intimacy that's being created in that circle, in that therapeutic circle. In that environment, in that patient-provider environment, there's an opportunity there to create a safe space and provide meaningful, high-quality information. There's a lot of information coming from many different sources, and sometimes it's hard to tease through. Patients come in and are like, I don't really know what to believe. Well, how do I really tease this out? Well, having that environment in that clinical space where we can at least start that conversation and then also appropriately refer, as we've talked about before, is going to be really, really important. If you look at most guidelines around the country, around the world that talk about diet-related chronic diseases, you're going to see food and nutrition, lifestyle interventions as a core component. But unfortunately, we haven't really given it the chance it deserves. When we create that safe space in the clinical setting, we give it the chance it deserves and really can move this work forward to improve and optimize the health of our patients and families.
Laura, anything you would add to that?
Sophie, I would add, love those points. And I think one issue that's really important is empowering our patients. I just recently met with a gentleman that was diagnosed with cancer, and he was feeling so overwhelmed. And there's so much misinformation out there, things that he was reading and being told that this will help you, stay away from this. And it was overwhelming. And providing good information, helpful information in a way that they could understand really does help empower. In addition, you really have to think about, there's so many things that are beyond their control. when they're having surgery, chemotherapy rounds and such, when they can have a little bit of control over what they're eating and be a part of that treatment plan with their diet to complement the other treatments so that they can improve their health. The shared decision making between our patients and clinicians goes so far in the patient's commitment to the plan. We need to understand their goals and where they are in terms of course, stages of change and such, so that we can provide the most in-depth counseling and help for them. So I really think that nutrition education, instead of being thou shalt eat this, it really needs to be about empowering them and sharing the decision making with our patients.
Can I add on to that?
Of course.
I think that was so well said. And it made me think about an example with hypertension. A patient comes in recently diagnosed with hypertension, and they're like, okay, what do I have to do, doc? And they're like, oh, you got to start these medications, is what we may say. But they're like, is there anything else we can do on top of that? And sometimes we may say, oh, you can eat better, right? But that doesn't tell you how to do it. What do you do with that information? Eat better. What does that mean? Where do I start? Do I, as a clinician, really believe in the power of quote unquote eat better? Or do I think it's just sort of a throwaway phrase? Do I recognize that in reducing my sodium or in helping this patient reduce their sodium intake, it can greatly improve their blood pressure? Do I recognize that improving other nutrient intake as well, like through a DASH diet, a low sodium DASH diet, that things can actually improve, that this is tangible, this is evidence-based, that can really improve the health of my patient or family, or is it throwaway? Do we give nutrition the chance it deserves? It's critically important. And like my esteemed colleague said, are we doing this in a way that's in shared decision-making? Are we activating and empowering that patient to really take over and control their own health? Are we giving them that chance? And oftentimes we don't. We skip those steps and move on to something that we think they're more likely going to accomplish. Give them a chance. That's really important.
Thank you. I appreciate that. And you're right. We've had some conversations with folks who want to do it and need to have the conversations and need to have that shared decision making where they can kind of learn from you as well, and not necessarily always turn to the pills to solve the problem, but really kind of giving education and with that. So one way in which the federal government supports Americans having a healthy diet is through the Dietary Guidelines for Americans, or the DGA. And yet a recent Morning Consult poll noted that about a fifth, so only 20% of Americans have never even heard of the DGA. So this is, as such, the BPC reports released today recommends that there be more dissemination of information. How can providers utilize the DGA and other resources to help with their patient education? Laura, you want to start with this one?
I'll start us off. And I want to reiterate that the dietary guidelines are general tips for healthy eating for a population. So they're a high level guidance and tool that we can provide. And so certainly providers can have that information available in their waiting rooms. And, when you go to the pediatrician, sometimes you get those handouts with different tips. The dietary guidelines, My Plate, can be a part of that. One thing with the dietary guidelines, though, is that when we're dealing with so many nutrition-related diseases and conditions, the dietary guidelines are for health, overall health and prevention. We then need to transition. We need to pivot to more personalized nutrition information that takes into account their medical conditions, as well as socioeconomic factors and beyond, and what their goals are too. So I think getting that general information out, we need more nutrition education in K through 12. Sometimes, with cuts in around curriculum, that information isn't provided, and health classes have been cut out. And so where can we embed good nutrition education in the curriculum in K through 12 and get it out to influencers too? The coaches play such an important role in children learning about and appreciating nutrition. So if we can provide those types of general guidelines like the DGAs throughout those schools and influencers, so we can start them out young and really impact them early in life and preventing disease. But also knowing when we need to pivot from general guidelines to medical nutrition therapy and personalized nutrition plans.
If anything you'd add to that?
Very little. I think that's spot on. You know, one of the things that I think about as a practicing clinician as well is like, where are these resources located? Are they easily accessible? Are they up to date? Can I use them? Can I easily print them out? Are they, if I print them out and they're black and white, because I don't have access to color printing, is it still visibly appropriate or aesthetically appealing to my patients and families, right? So I think creating those compendiums, those resource tools, and those databases where we can easily access them, they're easily able to filter through, that I can then provide them to my patients and families in clinical spaces and work with them to maybe circle things, highlight things, be able to present them in that kind of way is very meaningful. So I think that that's one way. Two, I think if you think about, you know, having these tools readily available for patients and families to be able to access on their own, as Lori's mentioning, right? So if they can go on these websites and these tools and pull them themselves and be able to easily read them and consume them. And then also, of course, educators. Are these broken down in a way that educators may be able to then use them and then use them in different settings? Whether it is those community cooking classes, whether it is other didactic sessions, food demos, whatever those may be as well. Whether it is in food as medicine programs, right? Thinking about the great demo we just saw with Food and Friends. Are we providing meaningful education in those food bags or boxes that the families receive? That is another way of receiving that education. One of the ways, not always the most effective, but can be effective as well.
Thank you for those comments. The Centers for Medicare and Medicaid Services has started to ask providers to screen for health-related social needs, including food insecurity. So I have a two-part question. What more could and should be done to assist providers in having the initial conversation with patients about whether or not they have enough food? And how can that conversation go beyond just solving the hunger problem and also address obtaining access to healthy food? Yes.
So,
you want to start?
Yeah, I can start this one. This seems like a plant for me. This is the work that I've been doing for many, many years. For years, I was working with the American Academy of Pediatrics, Food Research and Action Center, No Kid Hungry. And we were trying to figure out ways to really get providers across the board to recognize the importance of identifying hunger in clinical spaces. And then what do you do about it after you identify it? Not just screening to screen for screening's sake, but then how do you support families as well? I think some of the things that you can do is, number one, we can improve education of providers across the board, different backgrounds, right? And not just the epidemiology, the prevalence of food insecurity, but also the way that food insecurity affects the health of patients and families, how it worsens diet-related chronic diseases in households, how ER visits worsen, how increases healthcare costs. I mean, there's all kinds of associations, I should say, not necessarily causation, but associations that are involved there. We have to understand the impact on our patients when you understand the role of food insecurity. The other thing I think is important to recognize is how ubiquitous it is. Every single county in this country experiences food insecurity. When I start to ask providers around the country to screen for food insecurity, they're always surprised. They're like, I had no idea it existed to the degree it existed in my clinic, right? Because food insecurity is invisible. We can't use those same clinical tools we've learned in our training, our physical exam findings. If a patient has gained weight or lost weight, what laboratory signs show? We need to screen effectively. So one of the questions you ask is, what can we do better? We can screen universally across the board, all of our patients screen for food insecurity, incorporate it into other screening tools so that, hey, we're not biasing or using our own stigma to identify if a patient should be screened or not. Oh, you look like you should be screened for food insecurity. No, because it's invisible. If we do that in a way that's universal, we make this a standard of care. What some people call the hunger vital sign. This is one of the powerful screening tools. A 2-question screener uses the first 2 questions of the USDA 18-item gold standard screener. And it's really powerful in identifying in clinical spaces if patients are struggling or families are struggling with food insecurity or not. So I think that that's an important piece. So you prepare clinical spaces to be able to do this well so that it can create a system that lasts in the long term, right? Longitudinal approaches to doing this. You screen effectively using validated screening tools in clinical spaces. You then intervene effectively. How do you do that? connecting families to meaningful programs. Federal nutrition programs are quite powerful. They're evidence-based, they're cost-effective, they improve overall health outcomes. We know that we can connect many families to these programs, and they're underutilized in many degrees, in many cases, and they can improve health. So we can do that, and as well as other food as medicine programs, right? We've talked about some of these already. Medically tailored meals, medically tailored groceries, produce prescriptions. We can think about all of these different tools in really helping to impact the health of our patients and families. These are quite powerful. They're quite effective in doing that as well. And lastly, the thing that a lot of people don't talk about is advocate. We can transform policy through advocacy to improve the health of our patients and families. That is a really important piece here. And all of those measures are really important. The last thing, I'm over talking, but you talked about quality. How do we improve quality? That brings into nature this terminology we're using around nutrition insecurity, not just thinking about the amount of food, but the quality of food as well. Food insecurity is always incorporated a quality metric, but nutrition insecurity allows us to hyper-focus on that quality metric, on equity, on prevention, management, and treatment of disease. So we don't just need to think about those who are sick, but also thinking about those who we want to prevent from being sick as well. Using powerful food as medicine tools can be some of the ways in which we do that as well.
Wonderful. Thank you. I appreciate your passion. Laura, anything you'd add to that?
Boy, you hit it straight on, Kofi, straight on. One thing that I would add when we're talking about screening, you're right. The hunger vital sign is being incorporated in more and more health systems, and that's wonderful. But I think clinicians need to understand what food and nutrition insecurity can sound like. It can sound like in our older patients, well, I cut my meal that I get from Meals on Wheels in half, and I have half for lunch and half for dinner. Maybe they're doing that not because they don't have much of an appetite, but because they don't have another source of food for the evening. It may also sound like, well, I didn't take my diabetes medication, because, and what you need to delve into that a little bit more, because you can start to learn that what is really happening for that patient is they're having to make a choice between their medications and their food. So we need to go a little bit more into a little beyond just the tool and focus on what it may sound like. And I think that sometimes practitioners are a little hesitant to screen because they lack the confidence of, well, what happens if they are food insecure? What do I do here? I mean, if I come up with a lab panel that I know from that lab panel, I'm going to refer them to a nephrologist, or I'm going to add this medication. But what do we do with someone that is food insecure? And so I think being able to have that training on, here are resources, or here's the social worker, here's the registered dietitian nutritionist that you can refer to when you find out your patients are food insecure. And you're singing my song, food and nutrition insecurity. We have to go beyond just accessing. And many times the USDA food screening is based on income. And so do you have enough money to buy the foods that you need? It doesn't get into the quality piece, and it doesn't get into other factors that may make it difficult to access the food. I work primarily with older adults around food insecurity, and I'm actually developing a nutrition and food screener specifically for older adults, because financially they may have the money, but physically they might not be able to stand up long enough to prepare their food or get out to the store. So we have to expand our vision of what this issue really is. And it's about food and quality nutrition. And there are many things that impair that access to it. So I think the intervention part, as Kofi said, talking about the federal nutrition programs, and really they are successful because they put the food together with the education, and that's what makes it so much more effective. we need to embed that into our other food safety net. So at the food pantries, when they're going to pick up produce prescription, they need that education part too. Many insurance companies are now providing medically tailored meals through Medicaid to older adults, but they aren't necessarily as impactful if they don't have the nutrition education and counseling component too. So I would advocate for these programs, but also that they are partnered between the food and the nutrition education.
Thank you for that. We have an audience question. This is for you, Kofi. Does Elevance Health have an RDN or staff or registered dietitians they refer their patients to?
Great question. Just the framework wise, Elevance Health is a healthcare payer, right? So we work through commercial insurance, Medicaid, Medicare, duals populations. We're all over the country. And so in all of these different lines of business that we may call, we work with dietitians. We believe in the power of dietitians and work closely with dietitians throughout the country as well. So yes, we do closely work with dietitians and believe strongly in the power of working alongside dietitians.
Thank you for that. We're nearly to the top of the hour, so I want to give you each a few minutes to sort of say any last remarks or some other thing that you think is really important for us to take home today. Lori?
I believe this, I'm really excited about the work that's been done in this report that was just released today. Food in medicine is incredibly powerful. It recognizes the power that nutrition has in preventing and treating diseases. But further, it also recognizes the issue of nutrition and food insecurity and the impact that it has on the quality of life. The health issues that are associated with lack of access to adequate amounts of healthy food go beyond just hypoglycemia or ER visits. It impacts person's mental health extremely. And so we really do commend this report in recognizing the power that nutrition has, not only on physical health, but mental health too. And working together with nutrition education and food provision is critical.
Thank you so much for that. Kofi?
I would just add, let's keep the momentum going. The White House conference really brought a spotlight to this work. And a lot of this work that a lot of us have been doing for years. And the spotlight is on this work. We need to recognize and continue to recognize the power of food as medicine. We have to recognize the role in which food and nutrition, insecurity and poor diet, poor nutrition leads to worsening health outcomes. We see that there. We know food can be a powerful tool in helping to approach and fix this. We have to do this in a way that's meaningful. So White House Conference has been an awesome spotlight. Let's keep that momentum up. I think we have to continue to invest in food as medicine interventions, not just supporting them overall, but supporting the reimbursement of these interventions. When we do that and we move this work forward, medically tailored meals, groceries, produce prescriptions, federal nutrition programs, high quality nutrition education, public policy in this work. When we do that well, what then has to happen is that healthcare education has to go along with it. We have to have healthcare providers and future providers know how to use these powerful tools. In order to do that, we have to improve the education to be able to do that. So that's key to moving this work forward. And I just wanted to make sure we get that out there as well.
Thank you to both of you. They've been very helpful and enlightening, and I appreciate your passion, and we'll look forward to continuing to work with you. And I turn it back to you, Bill.
Also, thank you, Kofi and Lori, for this very, very informative and very useful discussion. We will keep the pressure on. That's the purpose of this report today. And thank you both for all the work you do to help improve our health through better nutrition. Once again, I want to close by thanking our co-chairs, our Food is Medicine Working Group, and our Food and Friends for your demonstration today as to how to prepare a medically tailored meal. And finally, from the BPC family to you and your families, we wish you a happy and a healthy Thanksgiving. Good day.